Welcome to the pharmaphorum podcast. This is Nicole Raleigh, and today I'll be speaking with Lee Lehman Becker, who is Roche's Global Head of Healthcare Insights at Roche Information Solutions, or RIS. We'll be discussing the liver disease epidemic that is being diagnosed too late and driving a growing health system crisis globally. Welcome, Lee.
Thanks so much for having me, Nicole.
So, understanding of liver disease is improving, and outcomes are increasingly determined by how early patients are identified, not just what therapies are available. But before we start exploring that in depth, Lee, I was wondering if you could perhaps briefly introduce yourself for our listeners and describe your own passions and your journey that led to today.
Yeah, thank you for that. So I'm responsible for the part of the Roche Diagnostics portfolio that brings digital products to patients, and hospitals, to labs, and to payers as well. And I really started a lot of my own personal journey in healthcare working in bariatrics. And this was a space where I actually saw really firsthand how devastating some of these silent metabolic diseases can be. We would have patients coming in who had lived their entire lives just morbidly obese. They weren't just showing up needing to lose a little weight. They were showing up with diabetes. They were showing up with degenerative joint diseases. They were showing up with chronic kidney diseases, liver diseases. And this, for me, just seeing what it meant for these people, where we were able to actually do an intervention, in that case surgically, that completely transformed their lives. We would actually see these diseases really start to regress, those that actually can be sort of pulled back in the course of its progression. And that for me just triggered a lifelong interest in working in these types of chronic diseases and really doing something that actually I think is a joint passion for me and for Roche, which is what we call prevent, stop, cure. So first and foremost, how do we really figure out how to not have a disease happen in the first place? Can we help a patient figure out how to live a healthier life, for example? Or if somebody's high risk, can we find ways that we can actually prevent them from getting unhealthy over time? Then stop. We need to diagnose something, hopefully as early as possible. Then we can do something like a therapeutic intervention, a surgical intervention, a lifestyle intervention. And then lastly, where possible, cure. And that's one of those areas where some of these diseases that I work in for a long, long time, there was nothing that really could be done out of saying, hey, we'd like you to lose a little bit of weight, please. We're starting to see actually that we can treat some of these diseases in really novel ways. And that is truly what shows for me at the end of the day, the value that we're bringing here.
Absolutely. Thank you, Lee, for that. So if we look a little bit closer at liver disease then, and then during our conversation, come back to these interventions and this very good motto, if I might say, of prevent, stop, cure within the space. Chronic liver disease affects around 1.5 billion people globally, while metabolic dysfunction-associated steatotic liver disease, or MASLD, now impacts roughly 38% of the world's population and continues to rise rapidly. So, Leo, I was wondering if you could tell us more about this, what might be termed silent epidemic, including why diagnosis as stands tends to come so late and the current approaches that we currently have, treatment speaking.
Absolutely. So silent disease, because for the most part, this is an asymptomatic disease until it's very far progressed. So by the time somebody shows up in a physician's office complaining about jaundice or about vomiting blood, they are quite progressed. And so you will have entire parts of the population who are just living with a disease that is getting worse year over year, and it's not getting diagnosed. And it starts out with inflammation in the liver. It progresses then to scarring all the way into cirrhosis, and finally can go all the way into a cancer form called HCC. And until those sort of end states where things are very hard to ignore, they just don't know. And typically their doctors may not be thinking about screening for a number of reasons. In some cases, the screening may not be part of just the routine pathways that a system or a hospital has in place. In other cases, it may be that for a long time, the diagnostics were not all that easy to do. So, for example, the standard liver markers wouldn't pick up on some of the early stage disease. And if there was suspicion that there was something happening there, a patient typically is going to have to go in and do something like get a fibroscan. Now, this is something that really is looking for changes within the structure that then sort of suggests function changes within the liver. Or they might, for example, have to go get a biopsy. And as we think about our healthcare systems, they're already overloaded. And so suddenly, if we're saying, hey, let's go get this patient in for something that's an additional step, that in many cases requires a trained professional to do, there's wait lists for these. And so you just end up in a cycle where people are not getting diagnosed. And then the waiting time to go get diagnosed takes longer and longer. And some people even drop out. Every time you add another step into a diagnostic process, people don't always go all the way through. So we really recognized that we needed to do something that would actually help us detect this disease state as early as possible in a way that was as non-invasive as possible, and also in a way that would really help patients just do it as part of routine care that they're used to getting. And then lastly, in a way that wasn't going to overburden these already super, super pressured healthcare systems. And that's where we started to look for alternative approaches to the traditional diagnostics.
So let's look at those pressured health systems a bit more closely. So you've mentioned the burden upon trained professionals, you've mentioned extensive wait lists, multiple stages, and indeed patients or potential patients dropping out before actually getting to the diagnostic that comes next. But we haven't spoken about cost. So when it comes to the wider health system, the cost of this disease is considerable at the moment. Metabolic liver disease is projected to affect some 1.8 billion people by 2050, with global costs expected to exceed $2.3 trillion. So I was wondering if you could tell us more about that, Lee.
So I think this is something that you've already called out. This is just such a prevalent disease. And it's something that's just getting more and more common. So if you think about the US alone, we're expecting that in the next 30 years, it's going to go up by another almost 25%. It's also something where as you have more and more people becoming obese or having type 2 diabetes, MASLD also goes up with that. So they're really correlated in terms of what it means for the system. And I think there's a few different ways that the costs mount. The first is when you get people who didn't need to be referred into a specialist referred. The second is when you catch somebody so late that you can't actually then go with, say, a treatment or a lifestyle intervention that may be lower cost. You end up with something that is very intensive. So, for example, liver transplant or intensive rounds of cancer therapy, as opposed to actually having the option to go on to some of the new therapeutics within light liver disease that came out in the last, say, 18 months. So this is an area where we know that if we can catch the disease earlier, we can start using these really effective therapeutics, we can actually lower costs really quite substantially. We actually did some look into this and we thought about what could a new optimized diagnostic pathway look like. And what we found actually is that the mean cost per patient with this optimized diagnostic pathway, so keep in mind, finding people earlier and finding people in a way that didn't require these invasive techniques or these very resource intensive techniques, it's about a 70% reduction in cost. And that for an overburdened healthcare system really translates into tremendous value.
Indeed, that's a considerable reduction. So let's look at the diagnostic itself, the potential for better diagnostics here. For listeners unaware, Roche Diagnostics has a broader focus on earlier detection and more precise diagnosis and is committed to tackling high burden diseases through scalable diagnostic innovation. So, Lee, the question you have been waiting for, tell us about the liver disease panel, Liver Pro.
So I think the first thing, and by the way, we're extremely excited to be bringing this to the market. The first thing I want to talk about is that it's actually something that sits atop our Navify algorithm suite. And that is a platform that is easily connected into both the EMR system of a hospital as well as the lab information system of a lab. And so it's the ability to actually bring in a platform on which you can run a variety of different screening and diagnostic and testing algorithms. Now, something like the Liver Pro is able to actually run on very common markers that are usually just readily available to any patient in pretty much any market. It can actually be quite effective with just about 3 out of the 9. As you add in additional parameters, accuracy tends to go up. But for example, with access to markers like AST, platelets, cholesterol, and just very basic information like age, we can actually give back to the clinician then a risk score about where that person is in terms of their progression, their likelihood of developing the disease. And it's a very easy to interpret risk score. I know sometimes historically there have been these sort of reports based on testing where one really has to have deep knowledge and look through all the different parameters and think about how would I interpret this within the context of this particular patient and what I know about this particular patient. And this score actually does that automatically. And so it really is just I see this and there's something I can do about it now.
Well, that's quite something. So what do you hope to see there next? What will bring to the system the, yes, the time is now moment?
I think the first thing is really that recognition that we can do something earlier and that actually the ability to have these very modern algorithm-enabled diagnostics actually opens up a new era within which every patient who is in some kind of risk factor, that could be that they are overweight or they have diabetes or they're really struggling with hypertension or they have a family history of liver disease, that they are then flagged in the system and these types of diagnostics, these types of screening algorithms can be really just run as a normal course of providing care for that type of patient. And that then means that we're able to catch this earlier. And then that full range of treatment options becomes available early enough that we don't end up in a situation where you have full cirrhosis, where somebody goes all the way into HCC. I mean, this is not just the vision for what we want to do in something like liver disease. I mean, the idea that actually we could have these types of algorithms available and running on standard blood work just routinely and catching things before they become something bigger. And then informing the clinician, hey, we've got something here. We'd like you to take a look at this. I also think that there's different ways we can think about optimizing this. And so if you are part of a healthcare system where you're really trying to make sure that you're not sending somebody to that really hard to book, costly specialist, we can optimize the algorithms to really be there to say, okay, let's make sure that we've got the exact right patient population before we refer them on. Similarly, if you're really trying to optimize around not missing any case, like a very advanced case, you can then pair it with some of our other algorithms that can really then heighten the ability to detect those cases. There's also that vision around doing something that allows the individual healthcare system or provider system to choose what's right for their patient populations as well as their own operating reality. And then lastly, I think that for me, the vision is also that we bring more and more of these treatments and hopefully eventually curative therapies to patients. I think it's been an amazing advancement that we actually do have some drugs that are available for treating patients with liver disease. But there are more out in the broader pipeline. We're actually working on that within our own Roche pharmaceutical pipeline as well. But that opportunity to just really think about how do we find that patient, diagnose that patient, and then bring them to a point where they are as healthy as possible. That's really the vision for me when I think about what we can do with things like Algorithm Suite and the Liver Pro algorithm specifically.
An algorithm beneficial for health systems indeed. Prevent, stop, cure. Lee, it's been a pleasure.
Thank you. You as well, Nicole.
And so that concludes another episode of the pharmaphorum podcast. You can find more information about this episode, including a download link and information about previous installments at pharmaphorum.com/podcasts. The pharmaphorum podcast is also available on iTunes, Spotify, Amazon Music, Podbean, and pretty much wherever you get your other podcasts. Just search for pharmaphorum and press subscribe. Of course, don't forget to visit our website itself, where you can sign up for daily and weekly news and analysis bulletins. And do follow us as well on X or Twitter and LinkedIn at pharmaphorum. That's all for now. Thank you for listening.